Good evening, everyone. On behalf of ICS, I welcome you all to this another episode of, or for that matter, another webinar on the role of interventional pulmonology in something very important we are excited about is the pleural diseases. We have a whole galaxy of experts and the panelists who are going to discuss each and every aspect of the role of interventional pulmonology in pleural diseases. Before I hand over the mic to Dr. Sonam Solanki, who is the moderator for tonight, I would like to thank our knowledge partner, Glenmark Pharmaceuticals, who have given us this platform to exchange our knowledge, our views, and ideas about all in respiratory medicine. Over to you, Sonam.
Thank you. Thank you to the Indian Chest Society for allowing me to moderate this session on a very important topic. And I would like to tell the audience that, it does not matter whether you are in a full-blown interventional pulmonology session. What we are about to discuss is relevant to each and every one of us as pulmonologists. So, hi everyone, I'm Dr. Sonam Solanki. I'm a consultant pulmonologist practicing in Mumbai at Sefi Hospital and Bhatia Hospital. Now, before I introduce our lead expert and panelist, I would like to start with this brief case. While we were preparing to, for this webinar or webinar on what all we want to touch upon, we realized that all of us had this similar case where a patient with massive pleural effusion underwent a medical thoracoscopy and a pleural biopsy, medical thoracoscopic guided pleural biopsy. Pleurodesis was done at the same setting. And as we would have it, that the reports were inconclusive. You sort of dig deeper, what else was happening, the number of samples sometimes is inadequate. Now the pleurodesis is already done and the patient visits another hospital with an ICD in situ and a very small loculated pleural effusion with no space to do any other procedure. And in these cases, at times, all of us unanimously, we realize that we've done a simple USG-guided USG-guided pleural biopsy, and that has given us a diagnosis of adenocarcinoma. Now, I discussed this story of our patients, not because, there are so many learning points on what is to be done. At what point should we start with closed pleural biopsies? Is there any role of that? How to increase our diagnostic yield, how to improve our patient care, should pleurodesis be done at the same setting, and so on and so forth. With this context, I would like to start introducing our panelists. So as lead expert, we have none other than Dr. Dharmesh Patel, who speaks so passionately about this topic. He is a consultant pulmonologist at City Clinic and Belal Amin General Hospital in Vadodara. And our four eminent panelists, we have Dr. Kanishka Kumar from MCRD Noida. We have Dr. Mir Faisal from Orzu Medical Clinic, Srinagar. We have Dr. Arjun Srinivasan from Royal Care Hospital, Coimbatore, and Dr. Shweta Bansal from Artemis Hospital, Gurgaon. So I would like to welcome each and every one of you, and I think we'll start the discussion without any delay. And we have 1 hour, which includes our Q&A sessions as well. So while we continue to have this discussion in the audience, if anybody has any questions, please put it in the chat box and we will sort of curate and discuss this at the end. So Dr. Dharmesh, I would like to start with you. You have such vast experience and interest, and you are so passionate about this topic. You can understand that every time you speak about pleural diseases, and you've seen, all these years. So do you think the management of pleural disease has really changed in the last 20 years with more and more, modalities available for diagnosis as well as treatment? Unmute. Dr. Dharmesh, you're on mute.
Great. Thank you. Now, can you hear me? Yes.
Yes.
So thank you, Dr. Sonam and Richa and all at the Apex Institute and the sponsors of this program. To answer your question, yes, indeed. I mean, it has clearly changed the way we've dealt with pleural diseases over the last 20, 25 years. And I think what's speared this is mainly two things. One is intervention. If there was nothing like an intervention, then maybe the interest in the pleural diseases would have still remained to an assumptive role of treating everybody with effusions as tuberculosis in our part of the world. And secondly, the excellent research work that went into pleural diseases with a lot of randomized controlled trial over these years, which sealed the fact that pleural diseases is something which can be approached in a more scientific manner. As in all cases, it's the necessity which drove people to look at pleural diseases. In the West, it was obviously the obsession with malignancies and the fact that there were a substantial amount of patients with pleural malignancies who could not be diagnosed with the steps in the algorithm which comes before the thoracoscopy. In other words, with pleural fluid cytology, with imaging, and even with sometimes image-guided biopsies. That's where thoracoscopy put its role in sort of a modern context. But it seems it's come as a full circle. And if you look at the history of thoracoscopy, it started with additionolysis. In other words, in order to manage patients with tuberculosis, if you look at Jacobius's surgery or operations, these were mainly dealt to cut the adhesions and therefore relax the lung and therefore help it to heal. Over the time, that changed into a more diagnostic role, especially in the 1950s and 60s, where a large number of our colleagues in Europe, spearheaded by people in Germany, in Austria, in Netherlands, in France, Italy, Denmark, etc., where these people found that, look, we need a little bit more good work as far as diagnostics are concerned. And therefore, I think thoracoscopy came into the picture. Many of these were physicians who couldn't rely too much on their thoracic colleagues to help them with biopsies. And then, so that picked it up, and other countries picked it up. India was also not left far behind, though it is still not that much used for diagnostic purposes as far as malignancies is concerned. But then gradually, as it expanded to sort of diagnose pleural malignancies by way of thoracoscopy when other modalities failed, it was soon found out that with refined imaging and with more sort of, expertise in image-guided biopsies, you could diagnose pleural malignancies without always doing a thoracoscopy, as specifically in your case, which will be interesting to really analyze as to what happened, and why an ultrasound-guided or an ultrasound or a contrast CT failed to pick up an abnormality in the pleura, which could have been approached through an ultrasound guided, and which mandated the need to go in with a thoracoscopy and do a biopsy, turned out to be inconclusive, and subsequently a simpler procedure like an image guided gave an answer. But that's something which can be left for discussion later on. Coming back to the point, and therefore with analysis, pleural fluid analysis getting smarter, our hands getting smarter, our radiologists getting smarter, our imaging getting smarter, it looks like thoracoscopy as a diagnostic condition is slowly shrinking. And we are now in our part of the world more resorting to, treating pleural infections. In other words, again, coming to the additionolysis, which all started off. So that's why I said it's come as a full circle. The indication was additionolysis in Jacobius's time. It then came to diagnostics. Now the role of diagnostics is slowly shrinking with good non-thoracoscopic modalities at our basket. And now what we are left with, at least in our part of the world, is managing pleural infections such as empyemas in their early stage with a removal of the adhesions. So in a nutshell, a lot of sea changes happen in pleural diseases, enough for any young colleagues of ours to add into their armamentarium pleural as a procedure, apart from the airway procedures which they do. And it's very rewarding, as all those who have engaged in will tell you. Right. So I think I could stop there as to give you an overall summary of how thoracoscopy has evolved over these years. And then maybe we can discuss over the next 1 hour all the various issues about pleural diseases.
Thank you, Dr. Darwis. Actually, that really, it's the answer you gave really summarizes your experience and interest both. So with this, I think I'll shoot the first question to Dr. Kanishka Kumar. Dr. Kanishka, can you briefly explain about medical thoracoscopy, various types, indications, and steps involved, etc.?
Yeah, thank you, Dr. Sonu, for the wonderful introduction, and Mason for the wonderful history of the thoracoscopy. I would like to just go in small detail and just tell you about the medical thoracoscopy in short. It's just a scope which goes through the passage. It's an endoscope, goes through the passage through the chest wall for the direct visualization of the pleura itself. Over the time, of course, the equipment has evolved. And though the pulmonologists do this procedure, so that's why it's called a medical thoracoscopy procedure, the surgical one. So the steps are very simple. You just have to prepare the patient and look for all the things which you see in normal bronchoscopy, like the blood profile and everything. Of course, the cardiac stability and everything. Then you just give a local anesthesia on the site, first checking after the site in the ultrasound where you want to do a thoracoscopic procedure. And then after applying a local anesthesia, you can give sedation also. Of course, when you are using a rigid bronchoscope, you should actually go for a small anesthesia or sedation too. And then you can go inside using a trocar. And of course, there are two methods by of doing the thoracoscopy, which is a rigid one you have and one a flexi-rigid also. Both have their own advantages and disadvantages. Like rigid can be used for adhesiolysis also, but flexi-rigid is very difficult. And of course, you get a bigger chunk of the tissue when you use a rigid thoracoscope, and which is more than the 5 mm, 7 mm size, so helps in diagnosis as well. But in flexi-rigid also, you can get a lot of specimen, because it's easy for the pulmopathologist to make a diagnosis later on. And regarding the indications, it's for the diagnosis of the pleural effusion. When you fail exudative pleural effusions, when you fail to diagnose even after repeated thoracentesis, and sometimes it's used in the indicated and also transudative also effusions when you fail to get an answer after repeated thoracentesis, and you can use it for diagnosis of the malignancies and non-malignant conditions like tuberculosis also. You can use it for cultures also, can be used for pleurodesis too. So there are a lot of indications nowadays which has developed and helped a lot of pulmonologists to use it. And that's all.
Thank you, Dr. Kanishka. I'll move the next question. I'll ask to Dr. Arjun, sir. You, of course, with your vast experience, and so two questions actually. One, do you have any comments on which is better? Say a new institute wants to purchase or set up a set for thoracoscopy setups, semi-rigid, rigid, pros and cons, and how do you increase the diagnostic yield of your thoracoscopy samples? Sir.
Thank you, ICS, and thank you, Dr. Sonam. I would start off by saying that the purist in me would want to say that let's go with a rigid thoracoscope. But practically speaking, if you are just setting up, if you're new into pleural procedures, if you're just setting up a pleural practice or intervention practice, you're just getting a bronchoscope, then a semi-rigid thoracoscope will be less intimidating for you to start off with, because it's exactly like a bronchoscope. That is exactly, that's another point, which Dr. Dharmesh mentioned. That also led to the explosion of pleural procedures in the last 15 years is the thoracoscope becoming less intimidating with the introduction of semi-rigid scope. So between both the scopes, if you actually look at the data that is available, though you get bigger pieces with the rigid scope, for a pure diagnostic procedure, the yield between both of them is no different. So now ultimately it is, if you're doing a diagnostic procedure, you're going in with a smaller scope, meaning which that the patient is going to be left with the less post-operative pain and probably earlier recovery. And now, if you are new to using a rigid scope, you might maneuver the rigid scope by hinging it over the rib, and the patient might develop, because of intercostal nerve entrapment, the patient might actually have long-lasting intercostal nerve-related paresthesias. So this is if you are starting off. So the next question as to how to increase the yield. Like I said, flexi-rigid versus rigid, by and large, for diagnostic has no difference as far as yield goes. But there are certain times where you would find that it is difficult to take with a flexi-rigid scope. So these are typically hard, flat top lesions, Or no, if you look at the West, it would be the lesions of suspected mesothelioma, where you'll have to take deeper biopsies, where the flexi-rigid may not be as useful. So here again, you've got few tricks that you can do. One is try and use a larger biopsy forceps. This has got a 2.8 channel, so it will allow forceps which is slightly larger. You can actually get it from your GI colleagues and use it. And you can use a forceps with a central spike. This again will help you get a better hold on flat top lesions. And the next thing is the most intervention suites tend to have cryoprobes these days. You can use cryoprobes also. There are some the data which is available which says that if you use cryoprobe, then you can get a bigger biopsy fees per se. And again, the number of samples also. So again, to increase the yield, first thing is what we have seen with experience is that in pleura, if an area is abnormal, then you're most likely going to get a diagnosis. Once you enter and you find that it is absolutely pristine looking pleura, then you are very, very unlikely to get a diagnosis despite taking biopsies. And sometimes you can have very, very small lesions, and with experience, you turn to search these areas which are not usually easily accessible, which is the costophrenic sort of recess, the recess between the costodiaphragmatic recess, wherein by convention also you expect, if you are looking at a malignant lesion, you're bound to have small nodules there. Sometimes if you are just starting off thoracoscopy, now if you have very few lesions, you might end up missing if you do not spend enough time. And again, like Dr. Kanishka said, the patient, you need to use adequate analgesia. Otherwise, you're just going to be fighting with the patient to try and get a look inside. And if the patient is actually straining, the lungs are not going to collapse. And if the lungs don't collapse, then you will not have adequate time to actually look inside and take a biopsy. So the other thing is about, usually whenever we go in and take a biopsy, we take about at least, 4 to 6 samples. And we also take adequate samples in saline, in addition to taking it in, for histopathology. And, as far as, whether there is any rose, as against EBUS, where there is a lot of interest in rose, there have been some papers, and I think there have been some centers in India also, they use imprint smears, which may be a good idea because as with respect to the case that was initially discussed, if they had done an imprint smear when they are not sure and they are actually picked up a diagnosis of malignancy, then again no pain. Especially if we are going to follow it up with the pleural disease. In case you do not get a diagnosis, then you're going to make the next procedure even more difficult. So these are the things that you can do to actually make sure that you have a proper inspection inside. Look at the areas which are difficult to usually visualize for few nodules which may be there. Usually abnormal areas will need a biopsy, and you can use biopsy forceps with spike, or you can use a cryoprobe if you find that you're finding it difficult to take biopsies.
Excellent. I think, sir, you've summarized quite a lot. And while you were speaking, one very important point, and especially in my case, was that the biopsies were not available. The blocks were not available for review, which also we see in our practice, where we have to make the arrangements. If the patient is going from our center, at least sometimes review of the slides is also very important. Dr. Dharmesh, sir, anything to add before we add to the we go to the next aspect of our discussion?
No, I think both the speakers have actually summarized things very well. The previous one about the indications and things, but I once again re-emphasize that in modern practices, we should not be using thoracoscopy for pleural disease purposes. That era has gone. It's not that we should pick up somebody and justify saying that I'm doing a thoracoscopy only to do a pleural disease, which we know now that even a simple chest drain or a small bore tube along with talc slurry or any other option options can improve that. So the indications in it's that small group where there is an undiagnosed exudative pleural effusion, and when we say that, it's a lymphocytic effusion with a low ADA and negative cytology where the clinical suspicion of malignancy is high, or alternatively where there is any other diagnosis concern, especially in TB, where things have not shown up prior to that. So that's the small area. And as I said, to a certain extent in our part of the world, that in the early stages of pleural infection, such as the exudative state or the early fibrilloproliferative stage, where you find thin septae or locules, where you can use this as a more of a therapeutic procedure rather than diagnostic. So in my books now, it has come down to, after all these years of using thoracoscopy, is only two: the undiagnosed exudative lymphocytic effusions, and secondly is in the early or the slightly second or week of pleural infections, where there is a fair amount of additional lysis required. And as far as the tips are concerned, Dr. Arjun has rightly said there are methods by which we can increase our yield by using various modalities, but we should not be enamored by the fact that we don't have other accessories. I don't have a cryo, or we can always borrow a large forceps from our gastro colleagues, which is there. So keep those couple of things in mind. But it's such a good procedure for diagnosis, be it adenocarcinoma, mesothelioma, tuberculosis, with yields increasing yields almost more than 95% in each of these categories. So you have to be really, unlucky to have a negative diagnosis in a thoracoscopy with a sensitivity rate, I think.
Yeah, I would like to add, just like Dr. Arjun has said, apart from the rigid thoracoscopes and the semi-rigid, we do have a mini rigid thoracoscopes also that has come in the last few years. And it does have the added advantages of rigid thoracoscope, taking larger biopsy samples and taking biopsies from the harder surface. But the outer diameter is only 5.5 as compared to 10 millimeter as compared to the conventional. And the working channel is also adequate. It's 3.5 mm. So this could be also one of the options where we can decrease the incision site, the length of the incision, and a little bit of pain also. That is much more concerned when we use a rigid scope.
And you would say the learning curve would be any similar?
The learning curve is the same. And though we did a study in AIMS comparing the mini rigid thoracoscope with the semi-rigid, the diagnostic yield was same. But the biopsy size was larger and the pain was a little bit more. But as compared to the conventional rigid thoracoscope, it does have few advantages.
Excellent. So I think we've covered medical thoracoscopy, malignancy, all that, and now moving on to the important aspect as far as our Indian setup is concerned: infections and intrapleural fibrinolytics. So, Dr. Faisal, can you just start the discussion on intrapleural fibrinolytics, the trials, the evidence, etc.?
Thank you, Dr. Sonam, and thank you, ICS. Intrapleural infections have been there. They have been there from we have been treating even from the past. We have been seeing that pleural infections have been there for a long time, and we have been treating pulmonologists before us, and after us also will be treating pleural infections. So fibrinotic therapy, which has been used and is currently being used, it has. If we go into the history of it. It was first described in 1940s, where Tillett et al. Had used that streptococcal concentrate, and then they used that for intrapleurally. Then there was streptokinase, which came in 1980s, and streptokinase was used in children, and then in adults also it was used, and it showed small trials. There were various trials that came, and it showed good results. Then we had the urokinase, which is a thrombolytic agent derived from human neonatal kidneys. Then there was a time when urokinase was hypothesized to be the best intrapleural fibrinolytic agent. And then we had various head-to-head trials between streptokinase and urokinase. There were lot of discussion was about urokinase and streptokinase, but all these trials were small trials. There was not a larger big trial, and all then came one of the biggest trials, which we call the MIST trial, the MIST-1 trial, which was the largest randomized placebo-controlled trial in fibrinolytic therapy. It had some 450 around about 450 patients, which were randomized to receive intrapleural installations of streptokinase and placebo. But then the results were not that good. There were no benefits offered by streptokinase in the rate of surgery and survival. Then the things started changing again, and then there was a era of using of DNase therapy, and then adding DNase with streptokinase and adding DNase with these agents. So it was postulated that with DNase the viscosity of the pleural fluid gets decreased, and then we are able to drain more of the fluid, more faster passage of the fluid is possible. Then Light et al. Confirmed the combination therapy of DNase with streptokinase and said that it reduced the pus viscosity as well as broke the bonds. And further studies were also done with streptokinase and DNase. Then came an era where tissue plasminogen activator was used, ateleptase that we call, and it showed very good results in initial trials. Then Zhu et al. Was the first trial with, who made a combination of DNase and ateleptase, and then we showed very good results. And with this combination, it was tried in humans, and then we had the recent MISH-2 trial, two study that was published in 2011, I think. That was a large trial, a randomized double-controlled placebo trial, wherein some 200 patients were taken, and they received tissue plasminogen activator alone with placebo, with DNase, and the combination was also given, and this showed very good results in the combination arm. So the combination arm in those patients, all 96% of patients who were treated were successfully managed without surgery. So this became the combination came into vogue, and now more and more people started using this. But then there are some issues with this combination also. But the other arms of this trial did not show that much of effect. So this combination came into vogue, and now it is being used by more and more centers for the treatment. But there are some issues with this combination also. There are the activator inhibitors are there in the pleural fluid, which tend to inhibit the action of the plasminogen activator. So we have to give different doses. We have to give in different doses, and so that we're able to dilute the fluid and decrease the viscosity of the pleural fluid. So this is how the history of it came, and how we are now we are using this combination. There are some neutralizing antibodies also which have come recently, I think they are in studies now, and which they have been using for neutralizing the inhibitors of the plasminogen activator. So let's see how those results come in. So with this, I think with this background, I think we can go into the fibrinolytic
you
therapy.
actually summarized a good amount of the evidence that is there, and but we all know we want these Respinars to be practical and applicable. So I would like to ask Dr. Shweta Bansal, of course, can you take this discussion further in terms of what molecules you all have actually used, the doses, personal experience, how do you select, what is the right time to do it, etc. And of course, I will shoot this question to Dr. Arjun also. We would love to listen to what he has to say about this as well.
So thank you, Dr. Sonam. As Dr. Faisal has said, we have three main important the fibrinolytics specifically, like streptokinase, urokinase, and the LTPase, that is a TPA. And the MISH-2 trial has given us the evidence that DNase has to be used with TPA to increase the drainage of the fluid, decrease the viscosity and drainage. So in the practice, initially, for the last few years, initially we were used mostly streptokinase we were using, but now since the MISH trial have come. So we have now more commonly shifted to the DNAs and TPA combination. And the dosing, if we come to that, streptokinase is mostly used in the doses of 2.5 lakh international units in the BD dosing for 3 days. And when we come to the combination part, there the TPA plus DNA, the TPA is used in 10 milligram BD for 3 days. In some studies, they have given for 6 days also, but most commonly it is given for 3 days, and with combination of DNA is of 5 milligram BD. But as there, Dr. Faisal has also pointed out, there may be few side effects also, like with TPA, we have a risk of bleeding. So there have been few trials which have lowered the dose of TPA to 5 milligram BD, and even one trial has shown that even 2.5 milligram BD in patients whom we suspect there is high risk of bleeding, along with the usual dose of DNAs, has worked well. So this can be graded according to the case-to-case basis, but usual dose is 10 BD for the TPA, and DNAs is 5 BD for 3 days. Like urokinase is, I have not used personally, and maybe it's not easily available, but the usual dosing is 1 lakh units for 3 days. And the most important question that comes to us is when to use this fibrinolytic agents. Once a patient comes to you with pleural effusion, and you categorize the patient according to the categories, the empyema categories, there are 7 categories are there. And once you diagnose that the patient has gone into the complicated thing, when your pH is less, the glucose is less than 40, and there is frank pus is coming, your gram positive cultures are positive. But initially, our aim is to give the IV antibiotics, adequate IV antibiotics, along with the drainage with the ICD. But once this therapy fails, or the patient goes into the loculated phase, that is, we have 3 phases in the pleural effusion in the development of empyema, like the early exudative phase, fibrinoproliferative, and the organized phase. It is the late exudative and the early fibrinolytic fibrinoproliferative stage. These fibrinolytics are effective. And so once you suspect early that now your loculations have started developing, your drainage is not adequate, what you had expected, your lung is not expanding, then you should look for the causes. First of all, you should look whether your ICD is in place or not, whether it's blocked or not, it's in the right place. You can do CT scans and imaging for that. But once all of this is done and your patient is not responding, the patient clinically is not responding, radiologically is not responding, your ICD is not draining well. So that is the time then when we should think of adding these intrapleural fibrinolytics.
Okay, Dr. Arjun, quickly, in terms of timeline, can you think it is 3 weeks, 4 weeks, and anything that you would like to comment?
Yeah, so we've all been seeing cases of empyema all our lives, and they have a miserable quality of life, absolutely miserable. So they go from our OPD, from the time I remember, they go from pulmonology OPD to CTVS OPD and back there. We say you come back in 2 weeks' time, and they say you come back in a fortnight's time, and that's what keeps happening. And that is something, that is something which is we need to consider, in the sense that we need to think as an interventional pulmonologist. More than interventional pulmonologist, you need to think as a surgeon in this case, in the sense that we are talking about DNAs and TPA. First thing is, how easily is it available? Second question is, what is the cost of the therapy? Okay, and even if you correct me if I'm wrong, even in the MIS2 trial, they still needed 10, 12, 15 days of admission. And you look at the empymas that we get. How many of these cases are you going to get in these fibropulmonary stage? These guys are neglected sort of empymas that you get. And our approach over the last 10, 12 years has been that if the CT shows loculations, and if there is an ultrasound which you're able to, if you're picking up loculations, we offer them thoracoscopy upfront. Now, we have gotten better at it over a period of time because our results have improved. Initially, we used to do it under conscious sedation, then we started doing it under sedation. Under GA. Now, most of these cases, we do it with a double lumen tube inside. Means that you got only 3 things to do. One is to make sure that you convert everything to a single locule. At the end of the procedure, you make sure that the lung is coming up, and make sure that your lung is separated from the diaphragm, and the diaphragm is moving well. So if you do these things, you're going to have most of the cases, unless and until you go and looking at a patient who's been having for a few months, most of the cases will have the tube out within a week's time, and they are home within now again week to 10 days time. So this is what and we see time and again. You have chest tube in situ, chest tube drains and it doesn't drain, it leads to more adhesions. Putting in a chest tube, unless and until it's a free flowing effusion, if you're going to have minimal or not already septations are forming, will not be a great idea, because at the end of the day, somebody has to manage, whatever adhesion that has been there. Because of the practical issues of not being able to get, and the fact that the stage at which you get these empyema, there is no trial. And if you look at pediatrics, right? Pediatrics, there is enough data from pediatrics to say that if you have a loculated empyema in pediatrics, the standard of care is an upfront VATS. There is enough data, enough literature from pediatrics, and the fact that over a period of time we've had these trials. First, the missed one, despite the fact that the missed one did not show significant improvement, because everybody had access to streptokinase, everybody was using streptokinase. Then came the missed two, and everybody's clamoring for that. So you also, ideal case scenario would be, you need to have a comparison between offering medical thoracoscopy or single port or a multi-port VATS upfront versus using these ITPlase plus DNAs. Till such time you get that, again, each center would continue to use what whatever they have access to, what they in their experience, they get the better result of, and the debate is going to continue.
Excellent. Dr. Dharmesh, the lead expert, will have the final verdict by the lead expert. So what is, if you could just summarize with experience, and if somebody like this is, because I face this in practice very often, our referrals are not streamlined. So we sometimes get patients tapped, comes to us in like 3 months, still has a large loculated effusion. Should we even try or just offer, and the cost of thoracoscopy, etc. So your verdict on that?
Well, I'm not sure the jury is out in this, but you said you started off your initial question is that in the real world scenario and practicality. But before I begin, I'm interested in asking the question to the speaker before, Dr. Arjun. Where does she procure the DNAs from? She said she uses TPNA DNAs. 2 months back, I did a WhatsApp survey as part of preparation for a talk. And I think Dr. Arjun was one of the respondents as well. I'm sorry I couldn't include all. None of the 50 had access to DNAs and not used it.
So we used in one case.
Not knowing the doctor where she's used DNAs.
So we used in one case, like it was 3 to 4 years back.
Yeah, that will not help you to conclude. I have used it in 5, in fact, having managed to get people's relatives from Germany and other places. So anyway, it's a one patient, that's right, because you don't get DNAs. I've tried every resources ever possible over the last 10 years, including contacting the Roche. And it's an interesting story for another day, where I was going to be put in a jail for somebody who actually conned our hospital into selling DNAs, and a company from Telangana who kept us fooling around for a month, and the hospital has paid that a tune of about 1,20,000, and we still haven't received the goods. So that's another story of how things happen. But also, let's get the semantics right. When we are talking about fibrinolytics or enzymatic therapy, fibrinolytics is restricted to only what we were talking about: streptokinase, urokinase, TPA. It's intrapleural enzymatic therapy where we are talking about DNAs. And the current talk is intrapleural enzymatic therapy, which is TPA and DNAs. It's no point discussing this therapy, no matter what MIS2 tells us. It is good. The 4-arm study randomized did show that TPA DNA 75% reduction in surgical referrals. Robust data, can't deny it, no matter how much you want to criticize it. The lead author of that paper was in Mumbai a month back. We discussed it at length, and sadly, we couldn't find any holes to punch into that paper. So it is a robust paper. The question is real world. And even in the real world scenario, when Gary Lee and his colleagues from Australia and other places did a survey of the real world practices, they found there were a lot of loopholes in, again, accessibility to DNAs, dosages of DNAs, whether to give it sequentially or whether to give it, concurrently, how much to give, etc. So it was all over the place, the methodology and the way you do intrapleural or enzymatic therapy. So when even those places who have access, there is still a haze about it. And then where we don't have access, it's better we don't talk about intrapleural enzymatic therapy. Does that mean streptokinase is no role? I don't think we can say that, because a lot of us have individually used streptokinase and often to good results, which is there. But the point is, you have to decide whether you want evidence or you want practicality. If you are a man of science, which we all are, and if you believe in evidence, then the evidence in all the BTS guidelines, including the new one which will come up, which says that single use of streptokinase is not to be advocated, right? That's very clear. If we need to push forward and say that, yes, it helps, then we need a randomized control trial. And my urge would be to, for platforms like this and the Indian Chess Society, is to try and get, we have the largest experience of it. Let's get together and show it. If it doesn't work, fair enough. If it works, it's been earth-shattering proposition. Therefore, coming back to what even Dr. Arjun says, yes, indeed, it's a good approach, because when you don't have drugs are working, or they are phenomenally expensive, or the whole therapy is to the tune of 2.8 lakhs at half the cost, probably you can do a procedure more effectively. But the point is that, again, we need evidence for that. Sadly, the trial between intrapleural enzymatic therapy versus early thoracoscopic additionolysis could not get off, because those centers in UK did not, time is essence in pleural infections. Just like Richard Light has said, the sun should never set on a complex pleural effusion. So if timing is adequate, none of the 15 or 17 centers in UK could say that we could offer thoracoscopy at the quick time. So if you couldn't randomize patients quickly into intrapleural enzymatic therapy or thoracoscopy, because they did not have access to the thoracoscopy room, they would not have a nurse, etc. Where else we don't face that problem at all. We can do it at 2 a.m. also. So what my urge would be to people like Arjun and all is, then let's do this trial and show that which is there. Indeed, I've seen him do that. I've myself done many thoracoscopic for additionolysis with good results. Timing is important, and as the colleague mentioned, that when the simple effusion goes into complex is a very, very fine line. You have to be vigilant. Third day, you do an ultrasound. When you find locules and when you find that the CRP inflammatory markers are not reducing, your chest drain is not pulling out enough fluid, that's where you need to decide. Intrapleural fibrinolytic or enzymatic therapy versus thoracoscopic additionolysis. And the decision would be on your skills, on your availability, and on your patient's resources. At this stage, I feel thoracoscopic additionolysis at this fine, small area probably is an edge over giving streptokinase alone, because the evidence is that alone streptokinase doesn't work. Till we as a group show that it definitely works, maybe the balance will shift.
Okay, just a quick follow-up, sir. I know we'll move quickly. Have you ever had a situation where you've done a thoracoscopy, realized that the adhesions are really thick, have put the ICD and then done the intrapleural or put streptokinase after that? It's in only, I think, probably 4 of half a dozen patients where after doing that in the same tube, you can also spray the fibrinolytics, which is there through that. It's only in a handful of places. And I don't think it's made a tremendous difference, because I think my patient selection was wrong. There were very dense additions. There was pleural thickening. Let me also remind Dr. Arjun emphasize the fact that, yes, indeed, you change the whole into a single locule. You see that the phrase diaphragm. But then if you have your pre-procedure screening very good, and if you see a pleural thickening of 10 millimeters or so, or even more than that, then that's the point where you say that maybe if I go in, I won't be able to do a complete job in stripping the whole pleura and freeing the lung, and the space problem might remain. So it's a very, very, very important screening of your procedure before you go in. Excellent. So we'll move on to the next aspect of our discussion. And Dr. Kanishka, Dr. Dharmesh mentioned it briefly earlier, but can we discuss on pleural diseases, various molecules, talc versus poodraj? Already Dr. Dharmesh mentioned that we cannot do for poodraj. We already have the slurry and the evidence around that. So Dr. Kanishka.
Thank you. For pleural disease, it's just a simple procedure which is used to obliterate the two obliterate the two pleura, it can be done by using chemicals, which is called a chemical pleurodesis, which for example, like talc pleurodesis, as you said, that it can be used in two forms, like talc slurry and talc pudraj. And you can use tetracycline derivatives like minocycline, doxycycline, silver nitrate, and povidone iodine is also used not in a lot of places. And anti-neoplastic agents are also used, like bleomycin, of course, with some side effects like oxygen toxicity, which is also heard. And mechanical pleurodesis can also be done using a laser, or you can do mechanically pleurodesis by pleural abrasions. Autologous blood patch can be used, and indwelling tunnel pleural catheter can also cause the pleurodesis. So for the indications, it's everybody knows mostly that it's used for the malignant pleural effusions, and it can be used with some evidence in non-malignant effusions like lupus pleuritis and chylothorax, and some kidney diseases also it has been used. And for recurrent primary or secondary spontaneous pneumothorax, it can be used. So regarding the talk about the choice between the talc slurry and talc pudraj, there are a lot of studies which has been done. And as Dr. Dharmesh sir already said, that he won't be using a thoracoscopy procedure just for the pleurodesis, which itself says that talc pudraj has no superior evidence than talc slurry. So of course I will stand by it, and I also think the same. ATS guidelines 2018 also says the same. Many other studies says the same, that talc slurry and talc pudraj has no difference when it comes to pleurodesis.
Okay, quick one word answer from all the panelists. What is the commonest molecules that you have used for pleurodesis?
We have been using talc all the time with the least side effects, and we are getting amazing results in metrocytic respiratory disease.
Dr. Arjun?
Yeah, we've used talc also, and we've used a lot of betadine for pleurodesis also. PGI had the paper on betadine for pleurodesis, and we've got some excellent results with betadine also. And so talc and betadine are the things that we've been using over the last years.
Dr. Shweta?
Yeah, betadine and talc slurry we use most commonly.
The Dr. Faisal experience or something
we have been I think we have been using betadine and talc is common. I have been using bleomycin also for I think many cases I have been using bleomycin with good results. I don't think as the literature says there are some side effects, but I have not encountered any side effects. I have been using bleomycin also.
In fact, when I was training, we used to use tetracycline as well. But of course, as we have more and more availability of talc and it's getting standardized, we moved completely to talc as well. Excellent. So I think, Dr. Arjun, next question, and the final aspect of our discussion before we take the Q&As is the latest kid on the block, which is the indwelling pleural catheter. So the indications, the procedure, your experience with it.
Yeah. Like Dr. Dharmesh said, the diagnostic thoracoscopies, the suspected, what you clinically suspect as malignant effusion, but you're not able to establish a diagnosis, wherein you used to, where the thoracoscopy used to be indicated. And even now they are indicated if you do not have a diagnosis before you go in. But once your cytology is positive, like you said, between putting in a chest tube and doing a pleurodesis, indwelling pleural catheters have really made the significant improvement in the patient's quality of life, because it's an outpatient procedure and you can do it under local anesthesia, and the patient, once patient is comfortable with the concept of having a tube inside, and you give the patient you give them the responsibility of managing the tube by themselves and managing the drainage themselves. Over the last, I would say 7-8 years, things have really started. Patients have really started accepting this. The major indications for the same continues to remain malignant pleural effusion, which is recurring. Sometimes we've also used it in recurrent transudative pleural effusions like hepatic hydrothorax, and sometimes very, very refractory, other transurethral effusions we've used. So again, there's been a lot of research that has happened in indwelling pleural catheter over the last few years. Initial thing was, like any new kid in the block, initially it came in as those patients where they were too sick for thoracoscopy. As a thing that they're going to have only a few weeks or months of survival, you give them something which is not very invasive and more comfortable to them. And slowly people realized, and the data also showed that they were having very, very good survival. People were able to tolerate it. And the longest we have had is for about 22 months, patient with an indwelling pleural catheter. And then, since our ultimate aim is to achieve pleurodesis, there have been multiple trials on how to do a pleurodesis with an indwelling pleural catheter, which might be, more frequent aspiration or putting in talc into that. Though the challenges that we face with an indwelling pleural catheter in India is the fact that you have to not only teach the patient, also sometimes what happens is patients come from far away, and though you tell them that they can drain the indwelling pleural catheters by themselves, the drainage system, which is a vacuum system, is quite expensive as a recurring cost. And then we have a roundabout way, and we have a way around, as most centers do, of not trying to use either. Some of the centers have tried using Eurobags, which are disposable. But what happens sometimes is that these patients land up in a local hospital, and when they find some catheter inside, and the physicians tend to flush it. So that's something we've had trouble with, despite the fact that we explained to the patient. And again, the cost of the procedure, if you actually look from if it is not an institution, and if you're looking at a corporate point of view, then cost of the catheter sort of gets negated by the fact that you can do it as an outpatient procedure, as against if you have to admit the patient for a couple of days. The recurring cost is obviously the issue, and the patient developing an infection is also an issue. So we'll have to get to a point. We are not been routinely doing pleurodesis through the indwelling pleural catheters because of logistic issues. And also the fact that we have not been able to drain these catheters every day, again, because of logistic issues. And we don't want the patients to handle the catheters a lot more frequently than they really have to.
Excellent. So I think the next question is to Dr. Shweta. She and I were discussing, we have put indwelling pleural catheters, but not that many. But so just as a newbie, you and me both, you think it is more difficult than pigtails, or you think the learning curve is really high? What do you think?
Yeah, obviously the learning curve is you need to have an expertise in that. But what I felt in my practice is the cost is a big issue. Even if you say that the long term, if you look into the cost effectiveness, the IPCs may be more cost effective than the pleurodesis if we look into the days of hospitalization and subsequent. But still convincing the patient for the cost for the catheter in private practice is quite a big challenge. And what you need to look into upfront is whether you directly want to go for the IPC or you go for the pleurodesis. But what I think is if you have an expandable lung, the lung has expanded after your initial ICD, you may also go for direct pleurodesis, because it will have once the drainage has stopped, it's good to have pleurodesis upfront, rather than putting the indwelling catheter, which is more prone for infections, more prone for blockage or kinking, and the self-care that is involved. So you will have to decide that on case-to-case basis. And obviously, non-expandable lung, you cannot go for the pleurodesis part. You will have to, it's always better to go for the IPCs.
Dr. Faisal, any additional experience, comments on this?
Yeah, I think IPCs have made patients' life very. Before IPCs, patient. Although we do have the cost issues, we do have other issues, infection issues, but the quality of life gets improved. I have seen patients with IPCs, if they manage well, if a patient is educated, it's the best thing that could have happened to a patient. But the IPC, if the patient is educated, if you are able to make the patient understand how to do it and how to take care of it, I think IPCs have made patients' quality of life very good.
Okay. I think Dr. Arjun briefly mentioned, like if I have to really term it, like the Indian Jugaad, where the IPC ideally is supposed to be attached to the vacuum containers. But recently I had a patient where, again, it was not draining. And the manufacturers only send me 10 photos of how it can be attached to the Eurobag. It can be attached to the normal ICDs, to the Synapy with a vacuum. So there are so many. Dr. Kanishka, any experience with the jugaad? Or, I mean, of course, I'll ask Dr. Dharmesh this question for sure, but any experience, or you all do the standard practice where you're attaching it to the vacuum bag and that's it?
Till now, though, we are using the standard practice only, attaching it to the bottle which we are given, the catheter. That's it.
You have all good patients. You don't have the patients like us where we have to think of 10 other things. So, Dr. Dharmesh, final say on using pleural catheter, your experience, you think the indications are expanding? I mean, if we were having this discussion last year, it would be different compared to what we are having today. So, your words, sir.
Not very as far as the expanding of the decision is concerned, but coming to the indwelling catheters, great stuff, great piece of, equipment. And as you would always expect, a lot of the studies will be pushed by the manufacturers, but, a tremendous plethora of advantages of the IPC in every study that has been done, upfront or after failed pleural diseases, aggressive drainage versus thrice a week drainage, results at the end of such strategies versus trying to put upfront during thoracoscopy and coupling up with the IPS Plus trial that is doing pleural diseases. If the lung doesn't expand, then the IPC is already in situ to drain. So you name it, and there has been all the angles in IPC management which has been covered by good, robust, again, data which is there. But again, I come to the point that where are we speaking about all this? We're speaking up at a completely different medical system where we have patients who are of a different nature. Ask the patient himself, what would you like? Would you like a tube sticking out for some time and when you go home? Or would you like a very quick admission to the hospital and do a procedure which then will remove your drain? It will help you and prevent the fluid from reaccumulating, probably initially maybe 70-80% of the time. But we all know that pleural disease is not a lifelong guarantee of, this pleural sticking back, and 50% to 60%, pleural disease failure rate has been seen over time. So this question, we leave this let this be the discussion point with the patient. One, to look at the very important is the social support. Is the relative or is the patient having access to people who can drain his IPC effectively with all these sterile precautions? The last thing you want is a patient of malignancy for which you have done this is to land up with secondary problem, which is an empyema. And though the rate which is there has been in the West has been about 5 to 6% or less than that, in my experience, this has been high because of a large number of factors which play a role in our part of the world. Again, no matter how much you teach the patient, they are going to about, I would say as many as 30-40% of my patients have landed up with some form of infection of the pleura, which over time has happened with the IPC. So I think three important factors if you want to roll out IPC in a large scale. A, the cost factor, which I think is important. Second, the social support of the patient. Is the patient in a position with his family support or a medical health support which can deal with? I remember in the West, when we used to put an IPC, our plural nurse contacted the district nurse. She went through a video recording of how the procedure is done and reinforced this whole thing over and over and over again on how to drain it. So I think it's very important, the money part of the thing, the social support point of view, and as I said, the decision which the patient takes. So it's a partnership between the both. Coming to the jugaad thing, I think the valves which are given, which is 350 to 400 rupees, which again the manufacturers give, valve is one. You want to use bottles, which is there, where you can aspirate this manually, just like you do that, again, always with the sterile precautions. This can be ETO'd about 2 to 3 times. So that valve, which is, which all of y'all must have seen, which comes with the IPC set anyway, these are available also in a set of 5 to 10. And negotiated rate can also be there, where the patients, many of my patients have used that valve. There was a paper sometime in Lung India also of another device, which they had, I can't remember very clearly, which they had used it upside down and had connected to the IPC. I can't remember it very clearly. It was one of the smaller centers, which was laudable. But I think sooner or later, the jugaad will come, which is there. I think IPC is a rich man's pigtail. The only advantage is it can be tunneled and it is very flexible. So this can be cracked by our Indian manufacturers. I envisage a time where in the next 2 or 3 years, we will probably get an indigenous intrapleural catheter, which will expand its use, which the technology or the equipment is sound. It's very appealing. The problem is the cost and the social support in our part of the world.
Spoken like a pioneer, exactly. So I think we've sort of covered what we thought we will cover in our webinar. Let's move to the questions quickly. There is no format to the questions. There are a few. So the first question is about the dose of streptokinase. Is there any evidence that a 7.5 or even higher 15 milligram per day gives very good results? So higher dose of streptokinase. Any comments?
Anybody who can take it if they want, but to my knowledge, I don't think there is any.
I mean, whatever positive result for streptokinase comes from small studies, and most of us use streptokinase out of conviction or desperation. So, no, you do not have any evidence to say that even 2.5 BD for 3 days works. So, 7.5, I'm not really sure.
Okay. The next question is, in case of tuberculous effusion or empyema, when to consider and what will be the duration of VATS? So I think for how long can you try in specifically tubercular empyemas, for how long can you try the medical management versus VATS or factors?
Okay, if I may take this. So we usually look at if they present with a multiloculated effusion, and we do not have a diagnosis also, then we upfront offer them medical thoracoscopy or VATS, however you might call it. Otherwise, if the patient has been started on ATT based on the ADA or the fact that he's clinically fitting into pleural tuberculosis, we usually wait for about 4 to 6 weeks to look for any resolution. And if there is no resolution at that point of time, we would like to know, because waiting beyond that would mean that the patient would probably end up, if the patient has not improved by that time, they probably end up with an open decortication and an ugly thing. So that is, we tend to wait for 4 to 6 weeks at that point of time. And if there is no improvement, then, we offer them thoracoscopy.
Okay.
I think six weeks is the time which we all anticipate to get some changes. If you don't find some satisfactory change, then of course you should refer for the VATS. Yeah. Same here. I agree with Dr. Arjun.
I think a great procedure for diagnosing or differentiating bacterial versus tuberculous empyemas, because both will give a very similar picture. It is, again, depends upon your clinical history. If the patient has a more acute history, it's bacterial. However, in both the cases, the ADA will be very high. Sugars will be low. Differentiating is a problem. So if you go by the way that, if you are that all bacterial or all empyemas are tuberculosis, then you may be often wrong. Conversely, if you think that all empyemas are bacterial, also you may slip in your clinical judgment. This is where a thoracoscopy helps, because that Lauder Kemper showed us in 70s that there is 100% pickup rate of AFBs either in cultures or in the granulomas. So I think it's a wonderful tool to differentiate between bacterial empyemas and tuberculous empyemas, giving you the additional advantage of the additional analysis.
And the earlier you do thoracoscopy in these patients, it's easy both for you as well as for the patient, because the longer you wait, it's going to be more difficult procedure, and the time to recovery is going to be higher. They might be left with the tube for a longer period of time. All those issues come in.
So, Dr. Arjun, just one quick question. Like if a person comes to you after completion of 6 months of ATT and patient is clinically improved, there is a little bit of improvement also radiologically, but there is a residual pleural thickening. Patient is asymptomatic. So,
for pleural thickening, unless and until the patient says that there is a significant restriction of activity at the for pleural thickening, we are not going to go back in. But if you're going to have a loculated effusion, which is likely, there will be a bag of pus sometimes. At that point of time, we might have to, because a lot of these, sometimes it might even be a chronic bacterial empyema, wherein it completely gets walled off. Whenever the patient's immune system sort of drops for whatever reason, then they might end up We've seen
Yes.
patients end up with sepsis. So this has to be, once you have a bag of pus sitting there, though the patient might be asymptomatic at that point of time, some way or other, this bag of pus has to come out.
What about some partially drained pleural effusions started on treatment, tubercular specifically? We see this very often in clinical practice. So they come to you, say, after 2 months, 3 months, intensive phase, then they're doing fine, but they have some. I recently had this patient. So would you attempt a medical thoracoscopy in this patient, or just do a CT upfront, look at the pleural thickening and send it to the surgeon?
Over years, we've started sending very, very few patients to the surgeons, and our thing for sending to the surgeon, which may not, again, it's center to center, is if we feel that it cannot be taken out with medical thoracoscopy bar VATS, the patient requires an open decortication, is when we would say that upfront you probably go to the surgeon. So that's what it is, and of course, this is it is purely based on the experience of the center and the fact purely looking at our results over the last 10-12 years.
So again, I think it's a word of caution, Dr. Sonam, here. As Arjun has said, this is a very, very specialized center. Arjun works very closely with the surgeons as well. So he is over the time been less of a physician and more of a surgeon, especially when it comes to pleura. So he can easily dabble with this. The message shouldn't go across that, this is something which we should dabble with. If it's a pleural thickening of any kind, it has to go to the surgeons unless you're very experienced, skilled to do all this stripping of the pleura business. Remember, it takes a rare amount of time. And the last thing you want is to just peep in and then do a half-hearted job and say, okay, ab theek nahi hua hai. Now a second procedure. The whole studies in pleura is the benefits and the advantages of a pleural intervention is how you can minimize a second pleural procedure. If you look at studies, what do they look at? Some endpoints that the patient does not go in for a second pleural procedure. So it's important then to only put your hands into such things when you are very, very thoroughly skilled with a very good backup center.
I think just to summarize for us, medical thoracoscopy sooner, better, less complication, and better outcomes, right? For the general public to or the younger centers. I think the next question is the role of intrapleural antibiotics in empyema.
Sadly, that has been shown in the past, and it hasn't found to be of great useful. The pharmacokinetics of intrapleural drugs, especially antibiotics, has not been so sound enough. In fact, there was a lot of plethora of trials in the mid 80s and late 80s, and then when it was found that it was not making difference, the interest in this waned off.
I think there is one question of a chronic BPF, I think, but that is beyond the context of this webinar. So unless Dr. Dharmesh, if you allow it, you want to add a few words of surgical treatment of chronic BPF, advancement in that.
Well, I don't know about the advances in that. The advances are not surgical. The advances are probably, airway through spigots and through glues and etc. That sort of which is there. Or through blood patches and things like that. I don't know how much of the chronic, if you define bronchopleural fistulas, are these going to be work. I have still a feeling that these patients who are very sick, if they are not very sick, working these airway interventions to close BPFs, or if they are very sick, which they are by that time, and if it's tuberculosis in nature, then it is best.
Okay. So I think if I'll just last 2 minutes for the panelists to comment if anything else. Otherwise, we've covered most of the questions. We've covered a lot of ground with evidence and with practical issues. And I think, the practical aspects of this. And I would hope that the whole discussion was in the interest of the audience, and there are excellent take-home points for everyone here. So last 2 minutes, anybody from the panelists wants to comment? Otherwise, we will wrap up this discussion. Okay. I think so. Thank you, everyone.
In one thing, Dr. Sonam, I can just add in one thing, which is there is a lot of excitement as far as pleural disease is concerned, and interest in pleural diseases, apart from other interests, will be just very rewarding. Over the last few years, excellent research work has been done. There is a lot of opportunities now in our country as well to participate in work as far as Plura is concerned. It's very exciting because all that we thought was tuberculous pleural effusion has changed our perspective when thoracoscopy came into mind. Let me not belittle this procedure. All I'm warning is, as we had discussed in your particular case, and as we've always been told by Dr. Mehta and Dr. Atul Mehta, is that every nail does not require a hammer, or if you have a hammer, everything does not look like a nail. So as in your case, let's not belittle a procedure like thoracoscopy. It has got its good place, it's got its good position, but if we use it wisely and judiciously, it is very rewarding indeed, just like use of intrapleural catheter. And my urge for the intrapleural enzymatic therapy or the fibrinolytic therapy is, let's get together. It's not very difficult to do a small randomized controlled pilot trial of streptokinase yet again and see if it works or not if we do it more scientifically. So the juniors who are in this logged in, there is Plura needs a healthy respect. Everything is not tuberculosis. Approaching it in a systematic manner is going to be very rewarding.
And I almost forgot, I had decided that I'll ask this question, that in terms of resource material, so we've discussed this trial, any books, any training programs that you think you can suggest to our audience who are juniors just starting out, centers where they can...
The training program is concerned, I think we are doing enough all over the country, apart from the workshops which has been done in the major national meeting of the society. There are a large number of small pleural workshops going on in almost every meeting. Dr. Arjun's Coimbatore place also does excellent pleural workshops. We currently conducted one at the Hinduja as well. So there are these pleural workshops which are going on, which is actually, I'm surprised to see how well it has been conducted, because you've got an ultrasound station, you've got a thoracoscopy station, you've got a pleurosynthesis, which is also an art, and to do that, an analysis of pleural fluid. So these are small stations all around. And I think pleural workshops has now become a part of this, just like this webinar has become. So I think there is a lot of out there literature, hands-on projects, etc., for anybody to be involved in. Just keep the eyes and ears open. Textbooks, a plethora of things which are up on the net. The textbook of pleural disease by Richard Light remains our Bible. And the thoracoscopic one with Pingley and Dr. Praveen Mathur in the past, who has passed away, is also another good Bible. So these are books which are there, but more importantly, the workshops, are very educative.
As sir pointed out, that ultrasound, learning ultrasound is a very important part of managing the pleural disease.
If you all think if the Indian context, the legal aspect of it goes away in the next few years, every pulmonology setup will have an ultrasound? Should.
We do have.
It should have.
ICUs, yeah.
Should.
It should have.
Should have. Okay, I think we've covered everything, and it's time to sort of wrap it up. Thank you so much for the time, the effort, the knowledge that you all have shared, and I think we can log off. Thank you.
Thank you very much.
Thank you, everybody.
Thank you so much.
Thank you so much, everyone.
Thank you, everybody.
Good night.
Good night.
Good night. Good night. Oh, there was one question. Right